Good day everyone. Today, we will be discussing about the drug named Labetalol. Labetalol comes under the pharmacological category of beta blockers. Labetalol selectively antagonizes alpha-1 adrenergic receptors and non-selectively antagonizes beta adrenergic receptors. The antagonism of different receptors gives different results in patients. Antagonism of alpha-1 adrenergic receptors leads to vasodilation and decreased vascular resistance, followed by a reduction in blood pressure. Antagonism of beta-1 adrenergic receptors leads to a slight decrease in the heart rate, while antagonism of beta-2 adrenergic receptors leads to some of the side effects of labetalol such as bronchospasms. Labetalol leads to sustained vasodilation over the long term without a significant decrease in stroke volume or cardiac output, and a minimal decrease in the heart rate. Labetalol competitively blocks adrenergic stimulation of beta receptors in the vascular smooth muscle, that is alpha-1 receptors, myocardium, which is beta-1 receptors, and bronchial, which is beta-2 receptors. The blockade leads to reducing the systemic arterial blood pressure, specifically through blocking beta-adrenoceptor notably in the heart, and from reflex-mediated drive caused by the peripheral vasodilation and systemic vascular resistance by blocking alpha-adrenoceptors in peripheral arterioles. Therefore, both the alpha and beta-blocking actions of intravenous or orally administered labetalol reduce blood pressure in hypertensive patients. Labetalol does not reduce cardiac output after moderate exercise or at rest. Normally elevated systolic pressure during exercise is lessened by labetalol, however, diastolic pressure changes are not affected. The beta-2 receptor blockade inhibited the reduction of isoproterenol-induced diastolic blood pressure. Due to their negative inotropic and chronotropic actions, beta-adrenergic receptor antagonists, for example carvedilol and metoprolol, are indicated in individuals with chronic cardiovascular disease like hypertension, coronary artery disease, congestive heart failure with a significant reduction in mortality. The FDA-approved indication for labetalol is the treatment of arterial hypertension, which ranges from acute hypertensive crises, urgent or emergency, to stable chronic hypertension. Labetalol in clinical practice has several common off-label uses that include acute hypertension in pregnancy and hypertension associated with acute ischemic stroke, and intracranial hemorrhage, including subarachnoid hemorrhage. Labetalol is often chosen as treatment of acute hypertension by anesthesia providers peri-operatively as it produces a dose-related decrease in blood pressure without reflex tachycardia without significant reduction in heart rate. These effects are produced through a mixture of its alpha and beta blocking effects. Labetalol is a common antihypertensive given in the post-anesthesia care unit. Severe hypertension requires prompt treatment with rapid-acting antihypertensive agents such as labetalol to avoid stroke and placental abruption. Treatment aims to lower blood pressure during pregnancy into the mild range, less than 160/100ths of a millimeter Hg, reduce the risk of stroke and other maternal cardiovascular complications. Due to the alpha-1 receptor antagonistic activity of labetalol, blood pressure is lowered more in the standing than in the supine position, but this can lead to symptoms of postural hypotension. When deciding to administer intravenous labetalol, the postural component needs to be considered when positioning the patient for treatment. Also, the patient should not be allowed to move to an erect position unmonitored until their ability to do so safely is established. Symptomatic postural hypotension is a potential occurrence if patients are tilted or allowed to change positions from the supine or seated position to standing too quickly. This is especially important in the postoperative period when managing a hypertensive patient with labetalol who can otherwise ambulate to the bathroom. Increased sweating, as well as flushing, have been reported with the use of labetalol. It seems the incidence of adverse reactions after administering labetalol seems to be dose-dependent. As with all beta blockers, labetalol has negative inotropic effects and has the potential to cause acute left ventricular failure if given in sufficiently large enough doses to those patients who have impaired function of the left ventricle. All beta blockers can exacerbate intermittent claudication and Raynaud phenomenon in patients with coexisting peripheral vascular disease. Another important consideration for anesthesia providers in the perioperative period is that non-selective beta blockers that interact with BEAT receptors can result in bronchospasm in patients with a history of asthma or chronic obstructive pulmonary disease due to antagonism of beta receptors. Sudden withdrawal of beta blockers can result in increased sensitivity to catecholamines. This upregulation can lead to tachyarrhythmias, acute hypertensive crises, and palpitations. Although this is more common with chronic use, its use is strongly cautioned in patients with bronchial asthma, overt cardiac failure, greater than first-degree heart block, cardiogenic shock, severe bradycardia, as well as other conditions associated with severe and prolonged hypotension. Of course, it should be avoided in patients with a history of hypersensitivity to any component of the drug formulation to avoid any degree of allergic reaction.
Thank you. Kindly comment for further queries and doubts.